Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Great. Well, thanks very much, Mark, for that introduction. I should say one of the benefits or adverse effects of having an office very near Stephen Scott's is that when you haven't given your title to ACAM, he pops down every sort of, half a day and says, "Have you got your title yet?" So I came up with this title, and like many people who want to prevaricate, I would slightly change it now to be the role of the psychiatrist within the multidisciplinary team in the care of people with intellectual disability, because I think I don't want anyone to take away the idea that the psychiatrist works as a semi-autonomous individual in caring for this very important group of children, adolescents, and adults, but rather that virtually all of our practice must be within multidisciplinary settings. And really, it's the fact that that isn't happening that led me to come up with that particular title. And it's a reflection, really, of what's going on in the NHS, and particularly in CAM services at the moment. I think I've been around long enough that I can remember first when virtually all CAM services excluded children and young people with intellectual disability from the services. And then NHS, it was before NHS England, it was actually Department of Health, said that one of the ways in which they were going to judge whether CAM services were comprehensive was the demonstration that there were services for children and young people with intellectual disability. What that led to, in some places, was excellent multidisciplinary services, but in other areas, really unidisciplinary services, or certainly not comprehensive multidisciplinary services. So, for example, nurse-only services for children and young people with intellectual disability. And we're sadly at another stage in the incarnation or sort of NHS cuts, whereby there's increasing pressure on CAM services. Our own local services in South London have been cut 30 to 40% over the last 5 to 8 years. And although it's not being stated overtly, in many places that means that children and young people with intellectual disability are being excluded in a rather more subtle way, where clinicians are saying, we don't have the skills to care for this group of children and young people. And by the fact that you're here today, I'm almost certainly preaching to the converted. But what I hope you'll come away from this talk with is the idea that actually this is an important and common group of children and young people who have mental health problems, and that we absolutely have to embrace their care in our services at every level. It's always daunting to follow from Chris Oliver, who gives such a beautiful talk and highlights such structured and detailed work in relation to identified syndromes and single gene disorders. Largely speaking, I'm going to be focusing on a much wider group of children and adolescents with intellectual disability, many of whom we don't know the cause. And sometimes we don't even recognize, and we'll get onto that they have an intellectual disability. So going on to really a different group of children. And I really wanted to start by highlighting the many different labels, of course, that we've used over the last 30 years when we talk about what we now term in the UK intellectual disability. And one consequence, of course, for a researcher when you're trying to systematically review the literature in the areas, it's almost impossible to do a literature review because there are so many different terms that are being used. You don't have a single mesh term that you can reliably use when you want to search the research literature. But I would also argue that this has had an impact on the identity of specialist services for children with intellectual disability, as we in the UK are currently calling it, ICD 10 and DSM-5 talk about intellectual developmental disorder, but I think at least with DSM-5 it's been ignored. And the fact that we don't have a single term that is well recognized in society over many years causes us difficulties in face recognition and the way in which we can easily promote the issues and needs of this group of individuals. That isn't, of course, driven by us. And just to wake you up after lunch, these were the terms used to define mild, moderate, and severe intellectual disability no more than 50 to 60 years ago. They were the technical terms for those categories and of course they're now words of, they're epithets used against individuals. And this is the challenge that we have. So we do constantly change our terminology, but I think it also causes us difficulties. So why am I worrying about the psychiatry of intellectual disability? Well, I hope this slide makes the point for you. These are epidemiological studies, and you'll all be well used to the idea that we do epidemiological studies, because if we do clinical studies, we're likely to pick up higher rates of disorder, higher rates of comorbidity. I would actually argue that for intellectual disability, the opposite applies. That if we look at clinical samples, we under-detect intellectual disability in our populations with mental health problems. So these epidemiological studies, and the ones on the left-hand side with a controlled comparison group of average IQ, and those on the right-hand side just looking at people with intellectual disability, or children with intellectual disability, show remarkable consistency in the rates of psychiatric or mental health disorders amongst children and adolescents. And for an epidemiologist, this is remarkably consistent, both in the rates of disorder in those with ID, but also the odds ratios, which are anywhere between 3 to 8-fold increase for those with intellectual disability. So just to also focus on how striking it is that two studies done in the UK, more than 4 decades apart, Emerson, which is based on the British Household Survey of Children and Young People, and the Roger Isle of Wight studies, are both picking up both strikingly similar rates, but also differences in rates. So I hope I don't need to persuade you that we have considerably increased rates. Now, what are the disorders that we see? And these are expressed as odds ratios, and I'm sure I don't need to tell you, but just to remind you, because the slides perhaps aren't totally ideal, but of course an odds ratio of 1 means that there's no difference between people with intellectual disability and those of average ability. So anything above 1 is an increased risk of having that condition if you have intellectual disability. And there's one disorder that's strikingly been left off this slide, and I'm sure you've all picked it up, even though you're slightly drowsy after lunch, and it's autism spectrum disorder. And the reason for that is if I put it on the same slide, everything else would be dwarfed. So the odds ratio for autism in this study was 70-fold, huge increase in people with intellectual disability. So what you can pick up is really right across the whole spectrum of mental health or psychiatric conditions, we have increased rates in people with intellectual disability. This is just to remind you that we think of intellectual disability as individuals with an IQ below 70, so the extreme low end of the normal distribution. The important thing to bear in mind for clinical practice is that not only do we need to define intellectual disability in terms of IQ, but also adaptive functioning. So the idea that your everyday functioning, whether it's communication, daily living skills, independence, that those are also compromised. In clinical settings, it's usually the case that that is so that adaptive function is also compromised. Not necessarily the case when you're doing research studies and epidemiological studies. And just as a sort of clinical plea at this point, that measuring adaptive function is often extremely helpful as part of your clinical assessment. We have two main measures that we use in the UK, the Vineland, which is an interview-based measure, and the ABAS, the Adaptive Behaviour Assessment Schedule, which is a questionnaire completed by parents. So it really requires relatively little from clinicians. And it can be quite revealing in terms of areas of function that have real meaning for everyday life of the family. People with autism, typically, whatever their IQ, typically have a discrepancy of at least several years of functioning, where their adaptive function is considerably lower than you would expect on the basis of their IQ alone. And in terms of managing individuals clinically, adaptive function is likely to be at least as important for you in thinking about how you organize interventions and the advice you give to family schools and other people involved with that child and young person. But having said that, so we're talking about disorders or individuals whose IQ is in the lowest 2 to 3% of the population, but given those increased prevalence rates, they actually account for 15% of individuals with mental health problems or psychiatric disorders. And therefore, I would argue that the care of people with intellectual disability and mental health problems is part of the role not only of every psychiatrist, but of every CAMHS service, and we can't exclude them from our care and consideration. Okay, back to our bell curve again, and I wanted to really highlight that it may be helpful to think about two broad groups of individuals with intellectual disability, and they tend to relate to the IQ level, but there is considerable overlap. There is, first of all, the group where we can identify the cause of intellectual disability, and a large and important part of those are the conditions that Chris was talking about before lunch. There may be genetic conditions with Mendelian inheritance, chromosomal conditions such as Down syndrome, but also what we call CNVs, or copy number variants, which are genetic abnormalities that we can now reliably identify with new sequencing, genomic sequencing and SNP sequencing that should be part of every genetic service that people link into. And so undertaking genetic analysis is really part and parcel of the diagnostic assessment for people with intellectual disability. It's also important to remind you of the acquired causes of intellectual disability, many of which will be more prevalent in lower and middle income countries, but which we often neglect in our own services. So things like fetal alcohol syndrome, we often forget to ask about parental intake of alcohol or indeed other recreational drugs, although alcohol is in fact the one that's most clearly associated with intellectual disability. But what we have here is the group who represent 50 to 75% of individuals with intellectual disability, for whom we cannot currently identify a single cause. And because of where they occur on that normal distribution, I hope it's intuitive that they actually are the majority of individuals with intellectual disability. Much of what I'm going to talk about in the next few slides will apply to them. What we know about that group of individuals is that genetic factors are important, but they're largely polygenic, and the research today on the inheritance of IQ, which is anywhere between 60 to 80% heritable, suggests that each gene accounts for 0.05% of the variance. So genes with tiny effects as individuals, and therefore we're talking about many genes acting together. But also importantly, where environmental factors are important. We're talking about heritability, so 60 to 80%. That means environmentalities, not a word, but we'll use it for the moment, of 20 to 40%. And those factors are important. And we'll see how they're important in psychiatric conditions and their correlates. And there's no evidence currently to suggest that the role of genes and environment for this group of individuals is any different from that for the rest of this bell curve here. Poorly powered studies, but nothing to suggest a difference. So sometimes I think of it as the extreme lower end of ability. But that comes with all sorts of adverse consequences. Okay, so we looked at the odds ratios for individual disorders, but what I wanted to do is turn that slightly on its head and look at the proportion of individuals with intellectual disability compared to those without who have different disorders. And the point I wanted to make is that although we think, for example, of tics and ADHD as being most strongly associated with intellectual disability in terms of odds ratios, in fact, they account for really a much smaller proportion of those who should be attending clinical services. And what you should be expecting to see in CAM services are once again the common disorders that we recognize. And when I talk about conduct disorder throughout this talk, I'm talking about both oppositional defiant and conduct disorder of any type. And the emotional disorders would be anxiety and depression. So largely speaking, the common things occur commonly in individuals with intellectual disability, and we need therefore to focus as much on good and effective interventions and diagnostic strategies for those groups of individuals if we are going to make an impact in serving this population. Okay, so we talked a bit about the role of environmental adversity, and again I'm referring to the work of Eric Emerson, who has, I think, really beautifully taken some of the cohort studies that have been done, both, we talked about the British household study, but also the Millennium cohort and some of the Australian cohort studies, and looked at them in relation to individuals, children and adolescents with intellectual disability. And this slide plots, again we're back on odds ratios, different psychosocial adversity factors and the odds ratios for those in intellectual disability compared to average IQ. What I want to take away is that every single one of these is increase in families of children with intellectual disability, most strikingly mental health, but every single one of them. And these aren't adjusted, so in aggregate, there will really be quite a significant impact. And this slide is showing us on your x-axis the number of psychosocial adversity factors for individual children and the percentage you have conduct, emotional, or ADHD diagnoses. And I want you to take away two things from this slide. The first is that even with no factors identified, the intellectual disability group have higher rates of disorder. But secondly, that those plots rise significantly more steeply in children with intellectual disability. So we might have had the thought that, oh, well, it's just part and parcel of their intellectual disability. They come from families where these issues are more common. We don't really need to take that into account. But actually what we're seeing is greater sensitivity rather than blunted or no sensitivity to those psychosocial adversities. And I think for many of us in CAN services, this plays to some of the strengths that we have, which are to identify factors that may play a role in promoting or maintaining mental health problems and identifying ways of intervening. So we need to be particularly aware of those in children with intellectual disability. And I also think of this as the converse to studies which show that having relatively higher IQ is a protective factor against psychosocial adversities. That's been a well-known fact for many years, perhaps first promulgated by Michael Rutter. But this is really showing at the other end we have greater sensitivity. Okay, and as an example Emerson showed that children with intellectual disability were twice as likely, if they presented with conduct disorder, to have persistent symptoms some 2 years later, and he looked at the factors that were associated with that, not all of which are psychosocial, so sex and language problems will come as no surprise, nor will perhaps the psychosocial adversity. But importantly, in that epidemiological study, it's showing that when those were accounted for, there was no greater persistence in the intellectual disability group. Now that's quite different from saying that if we do treat those problems, we know that the psychosocial adversity, if we had a vaccine for psychosocial adversity, all the conduct problems would go away, because this is an epidemiological study. We're looking at associations rather than causality. But nevertheless, it's giving us some ideas of where we might want to look and where we might want to test whether the difference is because we're dealing with different groups of children, those with and without psychosocial adversity, or whether the psychosocial adversity is playing an active role in the maintenance of conduct problems over time. And this is really just to remind us, again, as for those of us who are psychiatrists, that we need to keep our medical skills up to date, because individuals, including children and adolescents with intellectual disability, have much increased rates of general health problems, including sensory problems, hearing and vision problems, which often go undetected without, and they're a group who are at risk of missing their appointments for screening, of obesity, of starting to smoke, and hugely varying rates of epilepsy, but depending upon the study group, but certainly somewhere well in the middle of that. So we're dealing with a group where we actually need to ensure that they're getting good, both general and specific medical services, and that is one of the reasons why we need to have psychiatrists as well as a good functioning multidisciplinary team in caring for. Okay. Parents, and we've highlighted the role of psychosocial adversity as an important both initiating and maintaining factor for psychiatric problems in individuals with intellectual disability. This is looking at parents who have intellectual disability and the problems in their children. And again, we're on odds ratios, and remember, 1 is no difference. So what you can see is overall, very much higher rates of developmental disorders, speech and language problems, behavioral difficulties, and accidents. But once we account first for the social adversity and then for mental health problems in the parents, those odds ratios are massively reduced, getting close to, if not actually at 1. So hugely important to think about the context in which these children are growing up. And just we showed the very high rate, or the high rate of parental mental disorders. And we need to think about whether our parents of children with intellectual disability also have an intellectual disability or low IQ themselves. We talked about heritabilities of 60 to 80%, and we often intuit that parents may have learning difficulties themselves. Parents with who have intellectual disability are also, not surprisingly, at increased risk of mental health problems. So we have a vicious circle of familial and environmental adversity. So all that leads us to think about, well, you know, it's absolutely essential that we have effective and robust interventions for children with intellectual disability. What is the evidence base for that? And we'll turn in a minute to the broader evidence base, but perhaps the area where it's been best delineated is in relation to ADHD. And this slide shows us effect sizes where bigger is better, reflecting in standard deviation units, and your red column is the effect size for stimulant treatment in average IQ populations, which is between 0.7 and 0.8 in aggregate studies. That's a really clear message now. And the aggregate intellectual disability studies showed rates of roughly half that, which led us to do a study where we threw the best possible stimulant intervention we could think of at children with intellectual disability. So optimizing methylphenidate intervention to the individual child, looking carefully for adverse effects, and measuring carefully over time. And what you can see is our effect sizes are absolutely the same as those of the earlier studies. There's maybe more robust effect sizes, but we can go into that in questions and answers if you want. So we're really only getting half the magnitude of benefit for children with intellectual disability. It is a significant benefit, and the point you should take away is it's always worth considering whether medication is appropriate, because it clearly is better than nothing. But why are we showing such poor outcomes compared to typically developing children? And I think there are at least several different reasons. And I put a different disorder, but I should really say misclassification. So are we calling children who we've diagnosed as having ADHD, should they really have another diagnosis? Are we, for example, misinterpreting mannerisms and stereotypies as fidgetiness, autistic-like preference for attention on only very focal issues as global inattention, or, and so we're mislabeling children as having ADHD. I would argue that in general, the evidence is that we tend to miss ADHD in children with low IQ and intellectual disability. We tend to think that their level, that these problems are due to their intellectual disability, and therefore don't identify them for treatment. And that was certainly our experience in taking that trial. So we then need to think about different brain mechanisms, and Chris gave a beautiful example before lunch in relation to Smith-Magenis syndrome. Impulsivity may look at surface level very similar, but the underpinning mechanisms may be very different. And that's absolutely crucial to think about. We also need to consider whether the effect sizes we identify are real, or whether they're swamped by the general effects of having intellectual disability. Certainly my experience of doing clinical global impression scales with parents is they might give, say, oh yes, he's much better at concentrating, he doesn't move around so much. But no, he's really not better overall. And the question of whether the intellectual disability is sort of giving a global masking of an effect. But we also need to bear in mind that adverse effects may limit the way in which we can intervene. And therefore, for example, in our population, we had twice the rate of adverse effects leading to stopping treatment than we would have expected in average IQ kids. So I think this is where medication or any intervention has been well looked at, and we still have many questions. What do we know otherwise? Well, NICE, many of you will know, undertook a review of treatment for people with intellectual disability, both children and adults. And in terms of psychological interventions, they found 10 RCTs for psychological interventions directed at individuals with intellectual disability. In case you think I can't count, some of those trials actually had multiple arms in them. And so what you'll see is that there is a small evidence base, but if you look at those 5 RCTs for anxiety, they only include, for example, roughly 150 individuals, so they're very small trials each. And NICE had the view that they couldn't meta-analyze the results. Furthermore, the grade is the standard way in which the quality of trials and the quality of the overall evidence is evaluated, and that was seen as low to very low. Stephen will be particularly happy to see this. The one bright and shining exception to that was in parent training trials of intervention, where there was a clear demonstration of efficacy and benefit of parent-based interventions for younger children with emotional behavioral problems. It's even worse when we look at pharmacological interventions. just really a very profound absence of evidence for that group. And I really wanted to contrast the evidence for those with intellectual disability with a recent network meta-analysis that was done for depression in typically developing adults, or non-average IQ adults, which include 522 trials versus what we've got. And it's a shame. And one of the roles of the psychiatrist, as well as the academic professional in the care of people with intellectual disability, is to ensure that we develop an adequate evidence base for intervention, and that we don't let this shameful situation continue. The last point I want to raise before drawing to a close is, I think, the enormous potential of bringing objective measurements into the assessment and monitoring of interventions for people with intellectual disability. And again, Chris alluded to this to some extent, but more perhaps in an experimental setting. What I want to enthuse you with is we are starting to bring this in to people without intellectual disability. And there is absolutely no reason why we shouldn't be thinking how we bring remote monitoring and objective measurement in for people with intellectual disability. And I hope that all of you will be early adopters. So we're talking about remote monitoring via wrist held devices. How many of you have a Fitbit on today that can measure your activity levels and heart rate? But we also have more sophisticated Fitbits that can also measure your sweat or galvanic skin response, and as well as just activity levels, accelerometry, what kind of activity. So hopefully can distinguish, for example, fidgeting from mannerisms will be one of the ideas we have. And also using smartphones to look at where we are, what's the time of day when we get upset, what's our tone of voice from which we're beginning to be able to extract emotional tone, how do we communicate with others. So enormously rich opportunities for using remote monitoring. And I think we want to think about these in terms of both diagnostic interventions, where we're often limited in our assessments of people with intellectual disability who may have limited ability to communicate the subtlety of their symptoms. So we rely on parents, carers to give us high quality, accurate accounts, to be able to pick up subtle differences and to be able to read the differences between, for example, anxiety and anger, which may be better detected with objective measures, and to look for very subtle changes that may not be obvious, for example, from facial expression or activity level. We also have problems, for example, of getting routine information from schools and carers outside of the home. And finally, in intervention, I think because objective measures can allow us to get data right throughout the day and measure changes over long periods of time, we can pick up more subtle differences and pick up early differences as well, because the data will give us more power. So I hope you all will be early adopters. This is just to give you a sense of what data might look like. This is actually comparing actigraphy data and social communication data from a normal control and someone with bipolar. And what you're supposed to pick up is the more regularity across the time course of activity levels and use of different kinds of social communication in a typically developing person, a rather more random pattern for both of those in bipolar disorder. It's early days, but I think terribly exciting. So I want to wind up really by highlighting that psychiatric disorders are clearly increased in individuals with intellectual disability, and they're sort of marked by morbidity and psychosocial adversity, that there's very scant evidence for the effectiveness of interventions. And where it is, we really know very little about the brain mechanisms. And so finally, just to think about the way in which new technologies may help you in the future to deliver better care. Thanks.
It's not very often that we get an extra 5 minutes for questions and answers. So,
That was your hand waving at me.
10 minutes, 5 minutes, you did 5 minutes in one, that was miraculous. So, does anyone have any questions for Fred?
I've got one.
Great.
Would you say there are
Talking stick.
So stimulants for ADHD and intellectual disability work. Have you seen cases where it's been inappropriately withheld, where they've been better for having it? Because we're hearing this morning about possible overuse, but I'm interested in the other argument too.
The microphone's actually harming my brain. Say that again.
Sorry. Do you see many cases where stimulants have been withheld, but then they benefit when they have them?
So, absolutely. I think perhaps the most structured experience we had was in our clinical trial, where we were mainly recruiting from schools for children with intellectual disability. And in I think there were a couple of things that happened. First of all, the behaviors were seen as, well, you know, they're developmentally disabled, so what do you expect? So that's what we call diagnostic overshadowing. The intellectual disability is seen as the cause of everything, but also the mislabeling of ADHD, for example, as being non-compliant behavior. And that's as common in children with intellectual disability as it is in the general population. The take-home message must be that a large number of children, in our trial 40%, showed good effects of medication when measured in the most stringent way, compared to a placebo effect of 7%.
I have a question. Relating to where some behaviours that challenge others fit within the research, because much research has these higher rates of conduct disorders, that many of the children at lower levels of ability wouldn't meet the criteria for conduct disorder in terms of, as you go through, you know, the 25 questions essentially for opposition, defiance, disorder, then conduct, they're not doing the breaking of laws or even necessarily the breaking of rules, but they are hitting people, and that is their main, you know, presentation perhaps. Where do they fit? Are they fitting under emotional or under conduct?
So if I were giving another talk, and Chris had said some lovely things about challenging behaviour and the need to think carefully about how we use that as a term, because the greatest risk of thinking about challenging behaviour is we identify risperidone as an intervention for challenging behaviour. And the first point I would start at is, why is a child with intellectual disability engaging in challenging behaviours, whether it's aggression directed at themselves in terms of self-injury or directed at others in terms of hitting and so on, because very often those non-compliant, maladaptive, challenging behaviours can be masquerading. Chris gave some wonderful examples of how they maybe masking underlying physical and physiological conditions, but it can also be masking other psychiatric disorders, such as, for example, anxiety is the most common one in my experience, but also depression and even traumatic experiences. And so one should never, in that group of children, arguably many group of children, take those behaviours at face value, and thinking about them needs to be in the context of an overall comprehensive assessment.
Okay, lady up there.
Hello, I'm Harold Walters, community paediatrician from Cambridgeshire. I've got a question about identification of children with intellectual disability in current services, as I feel historically this has been partly the role of SEND services, and it seems to be that formal assessment is very much out of fashion and remains so, and so actually we struggle to get any formal assessment of children's cognitive ability other than school reporting. And I suppose I'm interested in your advice or other people's experience about how they manage that within their own services.
So it's a really important issue, and might say, and when is it important that we do identify it? This is certainly a topic when we did an ACAM masterclass last year, it came up a lot. I think my personal experience is schools are very good at reporting which children are achieving well below expected levels. If you can get reliable information from schools, and they probably, I would strongly advise CAM services to include a school report as part of routine assessment, in which you ask about how a child is achieving academically, as well as the way in which they present behaviorally and emotionally. And then I think it becomes a clinical judgment at what point in achieving below standard you decide that a cognitive assessment needs to be done. I found it helpful to have a lower threshold, that is, assess more frequently than less frequently, but possibly to use a screening measure, something like a British Picture Vocabulary Scale, which any member of the multidisciplinary team can administer and only takes about 20 minutes to do as a sort of screening. But I think it is, for everyone, it's a discussion with their local services about the importance of identification, because it may have implications both for that individual and the expectations of that individual, but also potentially we looked at CNVs, also potentially for the wider family. Before the break, Vicky Sloanens made comment about the lack of desire of educational services to label children, and of course labeling them as having low IQ is part of that. So it's really a dialogue that CAM services should be having with their LEA and their schools, because many aren't under the LEA, about how that identification is done and when is it beneficial.
Gary, there's a lady still in the centre, straight in front of you. Right ahead.
Somewhat now in relation to that question. So I think overall IQ is somewhat, I think, of limited value because so many children, they fluctuate, across schools, that they're more interesting often. Also, actually, though, in relation to this, I think that there are certain authorities, like for instance in Hampshire, they really don't do IQ testing, they work on the ones who've done an assessment. So, you're not going to get some information from them. But they would have plenty of information about the child's performance, but not in terms of being able to give you an IQ score. And I always find that the more functional assessment is particularly helpful rather than the IQ.
So, I think if I've understood properly, you're saying IQ can fluctuate. Should we be using functional assessment as well as or instead of IQ? Yes. So I hope everyone took away that I was highlighting the importance of looking at adaptive function as well as simply measuring IQ, and that there are measures that we can easily use in our clinical setting to do that, and that they are extremely helpful in understanding how a child is functioning in everyday life. IQ is in fact, over time, when you talk about fluctuation, there are two ways. One is fluctuation over time, and it's obviously, like any other test, you get variation, but it's a reasonably stable measure over time, so that unless we are seeing a child on a particularly bad day, you're likely to get something that is reasonably predictable over time. Variation across subtests is often informative, and in a world where we could do full assessments on every child that we're concerned about, I would certainly be encouraging a full 10 subtest IQ test. I'm trying to suggest that there may be some ways through for the busy CAM service where people may feel if they can't do a full all singing, all dancing assessment, they can't do anything. We need to find ways of identifying children whose interventions may need adaptation because of their learning. The number of children I've seen referred to me because they didn't respond to treatment, that was being delivered for 4 or 5 years, to find out that they had an IQ of 50 and no one had actually queried whether they had an intellectual disability because they're chatty. So I think there's a balance there.
You can't actually get it from
I think that is the world that we live in currently, and we need to both take that on board and work with our local services, educational services, but also think how we can close that gap, because some of the implications are for us as CAM services. If we don't identify intellectual disability and design our assessments and interventions accordingly, we will be the ones who are potentially negligent in the care of that child.
Okay, can I just make a plug for the ACAM website as well? There will be an expert reference guide on intellectual disabilities, and it will include a guidance framework about how to identify an intellectual disability using sort of an A to H alphabetical approach. So that should be out in the near future. There's a short form already out there on the net through the bridge, I think. So that's the end of Emily's Q&As. So thank you, Emily.
To be part of the advancement of child and adolescent mental health, visit www.acamh.org.